Ringer is off. I don't know if I'm live yet. Hi everyone, I am about to go live with a very good friend of mine and colleague. He is not joined yet, plastic surgeon. Oh, it's so nice to see so many familiar faces. Hi guys, thank you for coming in. So today I'm going to be joined with a plastic surgeon. So for those of you that don't know, I'm an oculoplastic surgeon, which means that I focus on the eyes in terms of surgery, and I do all the non-surgical. And Nav here, oh, let me see what happened here. Hi!
Hello, hi.
How are you?
I'm good, thank you. How are you?
I'm super well, so I'm very happy to be with you on Instagram Live right now.
Likewise, yes.
So I was just telling them that I specialize basically in the eye area surgically, and that you are a plastic surgeon, so you have full reign on the entire body.
I get, yeah, head to toe, literally, which is, yeah, I guess that's the reason I do plastics. That's the reason I chose it in the first place.
You like to have the diversity.
I like the variety. I'm always afraid of getting bored. I guess that was always my thing.
Oh.
And so I ended up kind of thinking, this was when I was a student. My simple thinking was, if I just choose the most general, which allows me to operate wherever, then at least, I can just have a bit of variety in my day, which I guess is kind of how it has worked out, because I literally could be operating on a head and I could be operating on a foot in the same day, I guess, in the NHS side. The private side.
What are you going to do on the foot privately? Not so much.
But privately, I don't do anything on the feet at all. But NHS, I do a lot of diabetic foot reconstruction stuff. Yeah, that kind of stuff. So, which, yeah, that's very different to, I guess, the stuff that we're talking about.
It is, but it's actually really nice to know that there's so many things that you do, because obviously, plastic surgery, oculoplastics, anything aesthetic, you always think of more beauty as opposed to, somebody who might need something that needs, a surgeon with aesthetic talent. So,
Exactly. We're always talking about, restoration of form and function, I guess. And on the aesthetic side, we're doing much more of the form side. But on the other hand, some of the stuff we're going to touch upon today, noses, that can be functional surgery as well because of breathing and snoring and damage after various things. So yeah, there is an element of function as well, I guess, to what we do.
And I wanted to ask you, I'm always fascinated with noses personally. So, I obviously don't do any rhinoplasties, but I do the non-surgical ones, which basically means molding things around with filler very, very, meticulously and slowly. But, most people who come in for a rhinoplasty, are they usually just first time, not I don't want to say first time, but what is their main concern? I mean, obviously there's the profile, but is it, do you do a lot of debulking? I mean, what is their bread and butter rhinoplasty?
Yeah, I do. I mean, I guess I do a lot of bread and butter, straightforward primary rhinoplasty. I do probably 20% of what I do is revision rhinoplasty, from other surgery done elsewhere, surgery that I've done a while back, and generally speaking, I guess the way we can probably distinguish what you do with noses and what I do with noses is that a simple rhinoplasty is actually reducing what you've got there. So I'm taking the bump, the bone, and a bit of cartilage away from the side profile. I'm breaking the bones on the side to narrow things in. I will be reducing the cartilage here in the tip, which are these little L-shaped cartilages that live in the tip of your nose. And we reduce the width of them. Sometimes they can be really curved, and we make them tighter and a bit more V-shaped, so you get a more defined tip. And then we might do some work on the septum, which is to straighten the nose out, or to help with breathing if that's an issue. A lot of people have got bent septums that they're either just born with or they've acquired as a result of an injury or trauma or sports. So what I do, my bread and butter rhinoplasty is we've had Ellie wave at us from the clinic. Hi Ellie. So yes, what I do is I guess reducing what you have generally. That sometimes I'll have to build stuff up, but that isn't a huge amount of my practice. It's where you take, perhaps some cartilage from the ear or the rib cartilage just underneath the breast.
Sounds so invasive, but you generally don't do that for like a primary. I imagine that's
No, it's really rare and it's not a big thing. And I can't. I mean, it is a very small part of my practice. There are other surgeons out there who do rib grafts every day, as it were, who are perhaps maybe the pure revision rhinoplasty surgeons. I do look at them sometimes, and I do think, gee, I wouldn't necessarily have done that because, I don't know, just because you can do something, it doesn't mean you have to do it. When all you have is
that's a much bigger surgery too. I mean,
yeah.
a primary rhinoplasty is quite involving, and then to take cartilage, I mean, that's almost like a small little operation somewhere else, actually.
Exactly, yeah, it is. I mean, and it's not, what, the rib operation is not necessarily a small operation.
That seems very invasive.
It's a fairly significant operation in that you will be going, you're removing a piece of cartilage. We're used to doing that, for breast reconstruction, we remove cartilage all the time to get to some blood vessels so that we can reconnect our reconstructed breast from using tummy tuck tissue. So we're used to doing it, but it is a fiddly operation, and it is, what I always think is, what are the things that can go wrong? What's the word? I'm a worrier, and I'm not a panicker, but I'm a worrier, and I think it's good to worry about stuff. Yeah, you worry about what's the worst case scenario, exactly, and then that means you can plan for the worst case scenario. So I'm always saying, yeah, but you know what? We can do this. We will probably get away with it, and the kind of things you want to get away with a rib cartilage harvest is not going into the lung space. And you don't want to be doing that in a small cosmetic hospital kind of place where we work, because if that happens, then you've got to take a trip down the road to the big hospital and maybe have a chest tube put in, all that kind of stuff.
Yes.
I mean, I'm exaggerating, and I am painting the worst case scenario, but
it's important to know, because I always tell my patients, for instance, in terms of statistics, I said, does it matter if I say it's 1 in 10,000 or 1 in 100? If you're that one person out of whatever the number is, you're going to feel terrible no matter what. So it's always better to know, even if the probability is with you that none of that is going to happen. It's always better just to know.
And
I agree with
that. And I think, that's my people like Ellie who've sat in on my consultations will know that I go through this mundane, boring list, which I'm about to make a video of, by the way, to put on Instagram so that people can see. I was going to use my poor daughter as a mock patient and consult her and talk as if I was talking to her, and let's see if she'll do that. And then also go through the complications, and so at least then people can listen to what I go on about in these consultations, because I do spend a lot of time going through some of the risks and complications, because doing the surgery, as you know, and doing what we do every day is the easy part, because we do it every single day. Handling the things that go wrong, which happen, but not every single day, is the difficult bit, is where you really need to think on your feet. You need to know when you've reached your limit. When do I call Maryam? Come help, please. I'm out of my comfort zone here. This has gone wrong. Can you come and please help me fix it? Or can I send the patient to you to fix it, please? I said this. I say this all the time. I said it last week during a live. Every surgeon knows how to operate. That's what we have been trained to do our entire lives, our careers anyway. What we need to work out is when to operate, when to not operate. And, if you have operated and things go wrong, then what do you do? And, the good thing about, people like yourself and myself is that we're properly trained. We trained with other people. I've just seen a urology colleague of mine join, I think. So, hi, Jonathan. And I know who to call if I have a problem, with whatever operation I may have done that hasn't quite gone to plan. And it may now be drifting out into slightly beyond my area of expertise. And I think, I don't know, what do you think about?
Well, I think it's really important to have a network of people, so from, I still am very much in contact with I did facial plastics too, so I did a very short fellowship with a bunch of plastic surgeons here in London, and also I did another fellowship just for eyes. mainly for blephs and ptosis and
Yeah.
bread and butter sorts of things, and I'm in constant contact with them. Obviously,
Yeah,
meetings
exactly.
are really important. And if I did have a complication that I didn't know how to deal with, and obviously we have a lot of information at our fingertips, and working in an aesthetic clinic where we have a number of plastic surgeons there and colleagues that you can sort of bounce ideas off of,
Exactly.
or the event of an acute emergency, to be able to go and say, oh my God, what should we do? I see a lot of, the people who, not so much surgical, although I am there for, I've gone and helped out fellow colleagues who had a complication and weren't in town, and I've, able to obviously help in some capacity. But most of the things that I do is really trying to reverse the damage that perhaps somebody else has caused elsewhere, who's kind of gone a little rogue, or didn't have the experience. I always say you're not really paying for a lot of people can do something well. If it goes well, then there's no problem. It's you're paying for the expertise and knowing how to deal with a potential complication, because sometimes it makes a big difference in the overall outcome. And so I think that's also very important to know. But as a whole, everything that we do is I always say one of the reasons I love doing what I love doing is I didn't want to do head to toe. I thought about it really hard. I really wanted to, first of all, I didn't really like anything from here below. I mean, I was like, no, I just want head. Didn't like ENT because I really hated neck dissections, and I thought it was like, oh my God, so tedious and so hard.
I'm not the biggest fan of between there and there, I have to say.
Yeah, and then actually I didn't even think about ophthalmology, but I had a colleague who was above me, and so I had a couple questions. For instance, like, to do oculoplastics, how can you go down this route? So for anything that's like facial plastics or head and neck above, you can have a few different routes, and one is doing plastic surgery, which is the entire body, and then there's two other routes that that I'm aware of, which is going through either ophthalmology and doing a fellowship for 2 years afterwards or more, and then the third way is to do ENT and also do facial surgery that way. But obviously this is a lot of training and time that goes into it, and knowing the anatomy and all of that thing. I always think the nose is really interesting also, because now we can do some non-surgical bits with it too.
Absolutely,
and,
I don't do non-surgical rhinoplasty, but really I'm thinking about branching into it perhaps, but non-surgical noses are not one of my things. And so, I'm always curious of how you would decide to do a non-surgical rhinoplasty rather than sending someone for a surgical rhinoplasty.
So there's a couple instances where I would do a non-surgical rhinoplasty before sending them out. And then I have a question for you about this, actually. So one is, sometimes I have younger patients who have come in with their parents, and ethnicity-wise, there are certain countries that have a disproportionate number of people having a rhinoplasty, and obviously it's better. I've heard it's better to wait. What is your when do you think, is a good time to operate? After what age? I mean, is it just 18, or do you think, you're still changing, evolving, so maybe it's a little bit better? I always worry, my question is that I think that the nose is evolving all the time as we age. So the nose at 20 might not look as good as the nose is at 50, like different, it just moves around, not moves around, but it's
certainly growing. I mean, I think your nose cartilage and your ears, especially in men, do continue growing as you get older, which is why the stereotypical old man has big ears and a big nose. That's if you sit in a pub and you look around, that's what you notice. Now, I mean, I'm generalizing a bit, but there is certainly something to that. And I think the nose, as you say, is evolving because your skin's changing. The thickness of your skin is getting thicker and thinner as you get older. There's also, I think, more than that side of things is the nose evolving. Therefore, are you too young for me to operate on you? I actually think age is important in that you need to know whether you want to have your nose operated on. Now, you might be 18 and classified as an adult, and you're allowed to vote, and you can buy alcohol, and you can go into nightclubs and whatever in this country. You know, you are classified as an adult at 18. However, I think a lot of kids at 18, kids, there you go. I call them kids. I think a lot of 18-year-olds are still teenagers. You know, 18, you're a teenager, 18, 19 by definition.
Yeah, of course.
And I think actually a lot of the stuff we do below the age of, I don't know, 22 is a number I have in my mind. Certainly for breast surgery, I'm always thinking 22 because breasts continue growing until the age of 22 on average. They tend to have stopped in most women by the age of 22. So if you then have implants before then, what if you then grow and you get much bigger? You've got to be really careful. With noses, I have operated on 18-year-olds, and I will do, and I don't have a problem with it, provided you choose the patient really carefully. And I think you've got to, that's the key. You know, I can operate on a 5-year-old and do a rhinoplasty in theory. Okay, and it's the same operation, it's the same nose. But a 5-year-old doesn't know whether or not it wants this bit of its nose made better.
Yeah.
Now, an 18-year-old is the same, and I think you need to be a little bit more mature, a little bit more sure of yourself before you do something permanent. And surgery, whether we like it or not, is permanent. And so I'm always really, really, really cautious when it comes to operating on anyone that is early 20s and younger.
Yeah, that's a good point. So a lot of times I do those younger patients because they're scared exactly for that reason. They might have a dorsal hump, or they have a little bit of a more bulbous tip, and they just want to have a little something to see if it's something they might like. And I tell them, you know, theoretically, if you do have a rhinoplasty, you wouldn't want to have any of this hyaluronic acid filler in that space when you have the surgery. But, you know, if you think you're going to not have surgery for a year, 18 months, then I'm happy to do some with you. So that's one patient, is somebody who doesn't want to have, the downtime, doesn't have the finances, because obviously it's a surgery at the end of the day. It's, you know, an injectable hyaluronic acid filler is always going to be less expensive. Obviously also, you know, temporary. It's for a year. And then the other patients that I do are often people who've already had a primary or even a secondary rhinoplasty, and they're scared to have a second one, or they feel something's moved and shifted, and they're unhappy with that scenario. And so, or I have somebody who's had a trauma and, you know, just doesn't want to have surgery, period, and says, I want to try this out. I will say most people who try it really like it, and I think they end up going on down the surgical route. And then, you know, and then there are some people who are so scared because they've had not the best outcome surgically, and haven't gone to the correct people, or maybe had the wrong expectations. But most of them, sometimes I see things that shouldn't have necessarily happened, and so they're worried. And so we just, you know, having that 5-10 minute injectable is much nicer than going under surgery. I will say,
So carry on.
Go ahead. You can.
Well, I was just going to ask you, you mentioned for a bulbous tip. So again, very simply, I think of non-surgical rhinoplasty as adding stuff to the nose. Therefore,
it is.
The nose will be bigger. So tell me your tricks. So this is what I want to know.
I think yes. Everybody always is worried when they have fillers in their nose, whether their nose is going to look larger, and that's actually not true. If it's done well, you can give the illusion. You can add height and volume without giving you width and I don't want to say depth, but without giving more width and making things more bulbous. So you can thin like a bulbous tip by elongating in the tip itself and creating sort of like a nice shadowing effect, essentially.
Okay.
The
So
nose doesn't
contouring.
it's more contouring. It's very small volumes. I never use more than, a syringe is a lot, I think, in the nose. Usually if I've done even that much, I've also placed a little bit in the glabella, or just up in this area, just to help smooth out some even lines or some volume loss there. But I generally, and sometimes I inject into the bottom part of the nose as well to help lift the nasal tip. So I think that's really important to say that, it's not one technique for everybody, just like a rhinoplasty. I'd love to have a rhinoplasty. If every one patient had one, it's not one size fits all, for anybody in this, in the aesthetics world, but particularly for nose.
Yeah, absolutely.
And I do want to say that for the nose, and then, we can move on if you want, but the nose also, you have to be very careful. So the people who've had previous rhinoplasty before always have to be careful. The nose has a very limited amount of blood supply to it, and obviously with scarring and surgery, you don't know what's been compromised and what hasn't, and you don't know what's supplying the tissues there.
Yeah. So
you have to actually go to somebody very good, because you never know. It's much easier to have a complication in that area in a previous surgical patient than it would be on somebody who's never had a surgery on the nose before.
And what I'd also say from my point of view is, if you're gonna, I think you should go to somebody who knows what they're doing when it comes to noses, full stop. I think going to somebody who does everything and then doesn't do very much in the nose is potentially setting yourself up for problems, because the other thing with the nose, the blood supply of the nose, is if you do inject filler into a blood vessel, there is the potential for cutting off the blood supply to huge other parts of the face, and some of the complications that you can see after that are really, really difficult to fix.
Yeah, some of them are disastrous. You do a lot of corrections. I mean,
yeah.
So do I. It's very sad to see sometimes, because again, like if you're in, complications can happen to everybody. The more you do, the more likely you are to have one. But recognizing a complication and having rapid treatment, again, is super important, guys. I wanted to ask you one more question about nose before we go on. Do you like to do, so I also sometimes put filler in the scar that's created from a rhinoplasty. Do you like to do open or closed rhinoplasties?
I'm an open rhinoplasty person. I'm of that generation. It's really interesting, actually. Originally it was all closed, and that's where the cuts are just on the inside. That's when I was training, it was called the old school way of doing it. And then people of my generation got trained by the Dallas Rhinoplasty school of training, really, is what we've all come through. Now, they were very much open rhinoplasty, which means you can lift the skin of the nose and you see everything underneath. It's like lifting the hood of a car up, so you can see the whole engine, rather than trying to just do it from the front, through the grille or something. Interestingly, actually, there's a bit of a movement back to closed now in what we're calling preservation rhinoplasty. And traditionally, noses have been filed this part down to get rid of the bump, cut things away, which is what I do actually still. I still do a lot of traditional rhinoplasty, but I'm also now doing a lot more what's called preservation rhinoplasty. However, I'm just doing a combo of preservation and open, because I still like to be able to see what I'm doing.
What do you mean by preservation? Like, what are you preserving?
Now preservation rhinoplasty is really interesting. This is where we can get a bit technical, so tell me to stop when I'm getting a bit too complicated. What you're doing is you're actually breaking the nose down the side, and then you now have this part totally mobile. It's kind of like you've taken the top of the roof of your house off. You've just cut it off, and now you have like a Toblerone that normally would sit on top of your house. You've now got that triangular shaped whatever Toblerone, and now what you do is you push it downwards behind the lower bone. You actually shove it further down in, so you still have all the natural curves and attachment of the skin to the cartilage, so you're not messing about with what is, so I have to take my glasses off, this is really, really thin skin, which is why you do see a lot of difference there. It's really thin skin. It's not quite as thin as the eyelid, but it's not far off. And so therefore, if you when you do operate on that area, there's the real potential for seeing all the bumps and irregularities, which I suspect is quite a lot of what you find yourself correcting with non-surgical, to smooth that out, because they don't like the bumps that are left behind. Preservation is a nice way of potentially avoiding that. it's being touted perhaps a little bit too much. Everyone is doing preservation rhinoplasty now. If you look on their website, so be careful, because if you do start pushing the roof of the house down, let's say there's a wall right in the middle of your house underneath. If you don't operate on that wall, which is the septum, you will bend the wall, because if you try and crush the roof of a house down, the wall's going to give way underneath. Does that make sense?
Yeah, absolutely.
And so what you have to do actually is take a section of the wall out, put it in very simple terms. It's a bit more complicated than that, because the shape of the nasal bones and the cartilage in the septum and the bone in the septum is quite complicated, and so you need to be able to cut it in such a way and reduce the bone in such a way that you're not going to make the whole wall collapse and suddenly you don't have a wall and you don't have a roof anymore and the house has fallen down.
That's kind of like the Michael Jackson nose, no?
Exactly, yeah. I mean, I don't know what Michael Jackson had. I don't think anyone does.
He had a lot.
Exactly. He just kept going, and that's somebody asked a question about repeat rhinoplasty. I think that was one of the questions that came through somewhere beforehand. Maybe in one of my little in one of my stories was, how many rhinoplasties is too many? Difficult to answer. Difficult to predict, but it's a law of diminishing returns. The first time you operate on someone, the potential benefits are going from, say, 0 to 100%. You may think your nose is at 0 right now. You want it to be 100, and that's what we're aiming for. Now, you never achieve that. Reality is that you will always fall short. You never hit the bullseye bang in the middle. That's life. So hopefully we get pretty close, and hopefully we get close enough. At the same time, you are taking risks, and there are risks which I'll say that much compared to the potential benefit. Now, let's say I take you from 0 to 85%. Now, you come back to me and say, look, can you just fix this, please? Just a little bit, please. I just want that, just a tiny bit. And I'm now going, okay, we're trying to go from 85 to 100. Okay,
yes, I see your point. Yes.
But second time, the risks go much higher, and suddenly the risks are way higher than the potential benefit. So, and that's less and less and less and less each time you have an operation, especially on the nose. It's true for a lot of other things as well. So what you want to do is probably prepare yourself for, look, what if the operation isn't perfect? And not even what if, it isn't going to be perfect, because nothing is perfect. I'm always saying I'm going to make you better, not perfect. And if I didn't think I could make you better, I wouldn't offer you surgery. If I thought I was going to make no difference or I was going to make you worse, then no, you don't operate, knowing when to not operate. And I say, no, you're better off staying well away from me. Perhaps go and see someone like Maryam, who can do something a lot more subtle and gentle, or try it out and see, because, so I've lost track of what I was answering, actually. I forgot your question. I'm really sorry.
No. I was just asking, what would we were just talking about the infrastructure and having repeat rhinoplasties, but
yes.
that's very important, I think, for everybody to know.
Yeah, I think be careful and be very sure before you go under the knife for the first time, and then, think really carefully about going under the knife again and again and again and again. And I get a lot of people who do come to me saying, look, I had this done, then I went there, then I traveled across the world because I wanted the best, and then I did this.
A lot of people like that.
And they're sort of a certain type of tourist, as it were, which I do worry about. And that's a red flag when people come to me giving me stories like that. I just quickly, whilst we're on the subject of tourism, we were talking about fixing problems. That's what I do pretty much most of my NHS practice, is fixing things that have not gone to plan, not complications in, say, cardiac surgery or brain surgery or spine surgery. That's a lot of what I do. And I'm fixing other surgeons, operations where wounds have broken down. All the surgery inside has gone well, but there's problems on the outside, and I'm helping wounds to heal. One of the big things I get in terms of corrections in the aesthetic side is cosmetic tourism, surgery abroad. And I get in King's in the NHS probably one tummy tuck a week coming back from abroad where things have gone wrong. And if you look, there's a few posts ago, I've put the story of a lady who came back and that's a pretty bad case. But you know what? It's not that uncommon to see cases that bad. And one of the things I just wanted to say, whilst we have people listening, is be really, really careful about going away from home to have your surgery. It's fine. The surgeons are good. The hospitals are good. The quality of the surgery that you get done is probably good, but the distance is a problem. And if you then come home and you have problems, it's really, really difficult to get here. I'm sure you see the same thing as well.
I have a lot of patients who travel everywhere. I do say to them that if I'm doing surgery, anytime I do surgery, I always say, look, or even injectables, I always say, listen, I now know your face. I have it documented how you came in. If I forget for any reason, I always have like a point of reference to go back to. But if you do a little bit with me and then you go and do a little bit with somebody else and a little bit with that and a third person and a fourth, and a lot of people do because they actually might not change their hairdresser, but they would more willingly go to different doctors.
Yeah.
And
it's unreal.
I find very odd, and I always say they don't know what you look like. So, I think sometimes people say, well, why do some people look so overfilled? And I said, either one, they like to have that look, or two, there was no, we as individuals forget very quickly what we used to look like. So if I've never been blonde, but if I became blonde, probably in a week's time, I would have forgotten that I was a brunette completely. And I'd look back at my pictures and I'd say, oh my God, I was a brunette. Same things happen with any injectable or, treatments that you do. If you do them and you like how you look, and even if you don't, you kind of forget what you looked like before. And then so you're kind of building on something that's not even you anymore. So I do think it's really important to sort of find somebody that you like, their attitude, their mentality, their results, and if you can, stick to them. I know we live in a modern world where everyone's traveling all the time, and people don't even live in the same countries, 1 year to the next. But as much as possible, I do think that that's really important.
I think it's really important, actually. I think one of the things is to establish rapport and trust with you have rapport and trust with your hairdresser or barber. We all have our favorites, and we know, or we can chat about the weather and the kids and the family, and holidays, and we have this link, and yet people don't want to do that with their surgeon, with their doctors, which is a real shame. And it's really interesting, actually. One of the things that I've been thinking about during all of this lockdown is how am I now interacting with patients? And I had to give a webinar to all of our plastic surgeons, our BARPS group, the Aesthetic Surgery Society, and I was asked, okay, so you're on Instagram a lot, Nav. What do you're the king, whatever. Tell us about it. And I went, well, actually, it's interesting. All I'm doing at the moment during lockdown is this. I'm doing a lot of these kind of interactions on social media, which I think is really important because I now finally have the time. And I'm doing a lot of virtual consults, and I'm sure you're doing the same as well. And it's really interesting. I haven't been a big virtual consultation person
me either.
up until now, but I really like it. I'm sold. I think.
I have to say, I don't think anything is going. I don't think things are going to go back to the way they were.
No.
With surgery, I can get a lot of the educational part done on a virtual consultation, but obviously, in order to have like proper measurements, I need to to attach to the patient and do injectables. I wish my patients are so sweet. I get messages every once in a while, and they're like, "Just wanted to say I really miss you," and you're my first stop when we're out of this.
Yeah, absolutely.
This is when that'll be. But I do think things will change with that.
I think so as well. It's and I think one of the great things about online consults is that they've become this pure getting to know you conversation, which I think is really important in medicine. I think you need to get to know me as your potential doctor if you're thinking about me, operating on you and doing some pretty major stuff. And I need to get to know you, that I think you're going to cope, and what if, all the things that we've talked about that I worry about. And I actually think these virtual consults, I might start doing them almost as a quick 15-minute starter or offering them out to people. But at the moment, everyone I've spoken to, I've got to know, and I thought, yeah, you know what, you'll do very well, or maybe you should speak again.
Agree. I've liked it too.
Yeah, and so I think that's going to be one of, we'll learn from war, as it were. A lot of what we do with trauma patients, for example, in the NHS, a lot of those plastic surgery are lessons learned in the war. The Second World War, the First World War, Gillies and Macindoe, and a lot of what we do with trauma surgery are lessons from the Afghanistan war in terms of resuscitating. And I think if you think of coronavirus as a war, which a lot of people are talking about, we're at war with the virus. That's what you hear the politicians saying. Now, I'm not entirely sure if it's that true, but we are learning lessons from these times of crisis.
Of course.
Yeah.
This is a time to refocus and find where where your strengths are and how to make things better.
Absolutely.
I wanted to move away for a quick question, because I keep getting this popped up on my screen. Someone's sending me a WhatsApp. So I've gotten this question a few times, slightly different to Corona, but in terms of, do you do eyes and eyebrows? So I've had a lot of patients always asking what they think of brow lifts, surgical, and whether they should be in combination with, I kind of need to bleph them, and that I'm moving my eyebrow around. But the idea of having a blepharoplasty plus or minus an eyebrow lift, and there is a surgeon who does that, that Croydon lift, which is putting your hair in a ponytail and lifting, basically pulling your hair so tight that you get a lift, but surgically doing that. Yeah, exactly. Versus just having a blepharoplasty, which is when you remove a little bit of skin from the upper eyelids and a little bit of fat. You can see actually a little bit of my fat has started to prolapse forward. It happens to everybody at some age, and some people earlier and some people later. Mine's about normal. I'm in my mid-40s, so this is when it's starting to prolapse. Joy's age. But basically this is that little bit of extra skin, and sometimes people try to do Botox to botulinum toxin to basically relax this muscle, this concentric muscle around the eye, which is known as a depressor that brings everything down. So when it's relaxed, it gives the lateral brow or the end of the brows a tiny little lift, and can sometimes make that hooding that happens in the corner of some people's eye a little bit less. Yeah, we have different eyes. Actually, it's a good understanding of the eyes, because everybody has, people sometimes think that I have big eyes, but I don't actually have big eyes. I just have a lot of what's called eyelid show. Yeah, and then there are people who have less eyelid show, mainly men. A lot of men do, and a lot of Caucasian, Eastern European, they're more likely to have it. I'm Middle Eastern, so this is an eye that is commonly found in the Middle East and Southeast Asia and Asia. The good point is, if you have a blepharoplasty, your scar would totally be hidden in your eyelid crease, whereas mine would take about 6 months to disappear, and then I might even have a little bit of whiteness just because of my ethnicity and the way that I heal. But what do you think about combining the two together? What's your general thought on it?
So I don't ever sell surgery. I don't ever try and upsell. No. I think that's a really, really bad thing to do in our industry. You're just heading for trouble. You come to me asking for something, and I say, well, Strata, why don't you have this done? Why don't you have that done? And then you get it done, and great. And then it goes wrong. Something goes not to plan. You'll look at me forever saying, it's only because you told me to have that done that I now look at me. Now look what you've done to me. So I never upsell surgery, but the brow lift is the one exception. And I don't think of it as upselling, but I think of it as saying, a lot of people come in saying, I think I need my eyelids doing, I look tired, all the usual things that people complain about. You do quite often see patients who have brow ptosis, and the reason I was just taking my glasses off, and I'll do it again in a minute, so I can't see the screen if I take my glasses off, but the reason I think I would benefit, as you say, probably from both. So if I just come close to the screen, and I'll try, there we go. So now, if I give myself a brow lift, I look a bit, I'm not doing it very well, I look a bit surprised, but I look a bit sort of less tired, a bit more awake. A little bit,
your lids are a little bit less heavy. Absolutely.
Exactly, and then there's an asymmetry. Which one? That one's the lower one. and actually my bony ridge where my eyebrows should live is there. So my eyebrows that used to be there have gone down to there now, and as I get older they'll do more and more of that. Now, as well as that, as you said, I've got eyelid excess, I've probably got fat herniation, and other signs of aging around that area. I'm a bit ahead of you. I'm 51. So.
Oh, you look so young.
Oh no! Yeah, daily plastic surgery. That's the secret.
Practice what you preach. You're self-operating now.
Someone asked me that last week. Actually, what have you had done? I've had nothing done. Can't you tell?
Not at all.
So yes, I do often, to answer your question, do consider offering people an endoscopic brow lift, which is where I make a little cut there, a little cut there, a little cut there, and then you use we've stopped using the camera really because we know our way around that part of the body, and we've read all the, that's the thing about proper surgeons. We've read the anatomy books. We know what we're doing. So I know where not to go and not to damage nerves that are coming out of the little holes above the eyes and so forth. And so I do what's called an endoscopic brow lift, which pulls, you separate all of the skin away from the bone here. Sounds quite brutal. And then
it is a little brutal. I mean, people generally have like a big headache afterwards, but it's a very effective way to...
Yeah, they do. They have a headache. They have a lot of swelling as well, that can take quite a while to go down. So I think I think a brow lift on its own is rarely enough. It's an okay operation. It's not a fantastic operation if you do it on its own. So I almost always, if I'm doing a brow lift, it'll be combined with an upper lift as well. Most
of
my
patients. How you say that. Because although it's not upselling, I would say that if you're going to do a brow lift, you might as well do your blepharoplasty at the same time, because if you don't, you'll likely need the blepharoplasty.
Exactly. And you'll have to come back, and it's more cost, more risk, more downtime, more, time off work and hassle and so forth, another anesthetic and all the rest of it.
Yes. And now, especially with, after, one of the things I think that'll be more thought about is having, anesthetic during surgery after, we go back from quarantine. Yeah. The other thing I wanted to say is when you're thinking about it, so for yours, you have had, because you also have thicker, heavier skin as a man, and so the ptosis will be, also you're 5 years older than me, so you have a few years ahead of me, but for instance, my brows are already on this orbital bone, which is where it should be. And so if I did if I were to do a blepharoplasty, I do have some skin. You can't, you can see that it's folded, but because I have a high eyelid, if I go it's more prominent in the morning. Anyway, if I do have a little bit, but if I did this right now, I think it's
too much.
Terrible. And so my distance is already quite high. So I feel it all depends on where your brows sit. So if your brows are tonic, then of course you do it. But I wouldn't necessarily do both together just because you're having surgery done. And I think it's more prominent in men than it is in women.
Yeah.
And so I think that's really important. And sometimes I even tell people, because for instance in my eye shape, which is where you have a lot of eyelid show, there's a tendency to also go a little bit, look a little bit hollow and sunken with time, because the orbital bones with time widen, and actually
everything shrinks.
It does fall back a little bit. The eyes do become or appear a little bit smaller with age. So sometimes even I don't even recommend removing like a little bit of fat, and I just redistribute it, because this hollowness usually happens along this border in the eye. And so I think that's really important too. And usually that's more for the older patient as well. And you can see it. You can actually see where the eyelid dips back into the sulcus there. So I think that's really important to consider. But all of them are really great procedures, and I think that the problem is there, you can't really say one. Again, not everything fits for every person. So
exactly, yeah. I mean, that's the thing. It's and again, a good doctor, surgeon, practitioner will have lots of different tools in their box, and they will know which one to pick for you, rather than just using the same thing for everyone. If all you know is how to fire a laser, then every patient that walks into your consulting room say, hey, suddenly magically they're going to be a laser patient because that's all you have. And so I think that one of the messages is be really careful about who you choose. Make sure that they're not just offering, they're not a one-trick pony, and they can do lots of different things, as we do.
And I wanted to ask you, what do you think of fat removal in the lower eyelid? Because there's a lot of controversy. So I see obviously a lot of eyelids. All my surgery cases are eyelids, and I do them privately, but then I do a lot of non-surgical as well. So again, a lot of people don't have downtime. They don't want to have the cost of surgery. Having a smaller cost once a year is more financially viable. Also downtime, taking off from work. The eyes are very visible. It's not like when you have body work done, your breast or your abdomen, you can sort of hide that with whatever it is that you're wearing, and you might not feel great, but I think kind of sometimes the face ones, the eye ones, you feel fine, but you just don't look great. And then the body ones, after a day or two, you feel fine and you look good. So you can hide it a little bit better. But what do you think? Because I feel like there are a lot of plastic surgeons who think that having fat removed from the lower eyelids is like a no-no and that shouldn't be done.
I'm probably more in that school, I guess, because I probably am. I remove very little fat actually in both upper and lowers. It takes a lot for me to, you need a lot of herniation of fat coming through and being a really obvious problem before I'll remove fat, because I don't know, I'm a simpleton. For me, as you get older, the bone is shrinking, the fat in the face is atrophying, and perhaps it's not that the fat has herniated sometimes, it's just that it's become more obvious because everything around it has gone backwards. So I wonder quite often when I look at patients, I'm thinking they're better off with something to fill, fill the tear trough area, not the tear trough area itself, because tear trough filler goes below, but I think they're better off having the tear troughs corrected. Yeah, exactly. Having the tear trough corrected non-surgically, and use temporary filler to start off with to see if you like it, and then maybe think of fat injection into that area. But I don't do fat injection into the face at all. It's not something I've ever done, and I worry about it a little bit as to how they're going to look later in life if all the rest of the fat shrinks, because fat never forgets where it came from. If you take tummy fat and you put it in the face, if you're the kind of person that gains weight in your tummy, you will gain weight here. If you've had that fat transferred, it receives the hormone signals to grow forever, and regardless of where it lives, but it remembers where it was born.
I've had two patients like that where I've had to remove previously grafted fat. Remember also for fat for the eyes, the eyelid skin is the thinnest on the body, and it's not very forgiving with any lumps or bumps, and so you have to be very cautious, and I would say almost less is way more in this scenario than the other way around.
I think the face that's a really good phrase for the face generally. I think we can all spot the overdone face, the overdone nose, the overdone eyes, a mile off, and these are all the things you'll see in the papers and online and so forth. What you don't see, and actually there will probably be somebody on every tube train you're taking who has had good plastic surgery. Every carriage that you're sitting in probably has at least one person who has had really good plastic surgery of some sort. The reason they've had good plastic surgery is because you can't tell. The best plastic surgery, I'm sure you're the same, is the stuff that you just can't tell they've had something done. They look natural. They look great for their age. They look, people, I'm often saying to patients, you'll be surprised. Even your mum might not notice you've had your nose done. What she'll probably say to you is, you're looking well. Have you got a new boyfriend, or have you been on holiday, or have you been on, been eating well?
They can't put their finger on it.
Yeah, you just look better, and that's the key, I think, to good aesthetic surgery on the face, is the better, not the younger, not the trying to, look like somebody else. There's no point trying to look like another celebrity, for example. You can't do that. It's just looking better for who you are, looking like a better version of you, I guess, is the thing to say.
I think that's the best way to put it. However, I would say for the fat around the eyes,
let's have this.
I think a little bit differently, just to give you a different viewpoint, is that I think sometimes as the bone, so there is an amount of fat that we all have in our faces and in our eye area. And as the eye sinks backward, then some of the fat that's behind gets pushed forward a little bit as well. And so I think if you look at older people, and I'm, in their 80s and their 90s, who haven't had any treatments or any surgery done, you will notice that they do have a specific fat pad here that is, of course, I agree with you, more noticeable because now they have ptosis of the midface and just a lot of volume loss, as well as changing in the bony structure, so they have a lot of loose, older skin to begin with. And so this part of the face is lower, and if you lift everything, that fat might not be as noticeable. But I also think that there are some people who I do a lot of fat repositioning, and I remove fat. I definitely remove fat, and I have a large number of people who actually come who have had a lot, who are young and have quite a bit of fat prolapse. And I think in those people, people are always commenting, you look tired, you haven't slept, like what's wrong? Did you sleep here last night? They get really bothered by the comments because they're like, no, I had like 10 hours of sleep. I just came back from holiday. And, like it's really demoralizing when somebody feels that they feel great, but that doesn't project in how they look. And so I do take fat, but I am conservative, and I'd rather take less. It's always
absolutely more. I'm a real chicken. If I remove fat, it's a tiny amount. I'll do everything I can to try and at least convince myself that I've done some sort of hernia repair, as it were, on top to keep things pushed down. I'm not sure if that lasts, and that's one of the things we argue about. But I again, less is more. I would rather remove too little fat and then come back and do a bit more if necessary than the other way around, because I think the consequences of overdoing it, and again,
horrible.
I hate the hollowed look, and there's so much of it out there, and people have had their whole faces ruined, I think, just by having their eyes hollowed out too much.
I think with that, and also the buccal fat, so many people, I saw there was a question earlier about buccal fat, and buccal fat, I always say buccal, I don't know why, but anyway, but that, I also, I know that like in this world of high definition, and everybody wants to be contoured within an inch of their life, and they want that sort of look. I think when you get older, it's almost like a fake dimple that doesn't look like a dimple, and it just looks like really hollow, and then that little sliver of fat, you never want to get rid of your fat, guys.
Exactly. I think, I have not done many buccal fat reductions, and again, I worry about it hugely because of exactly what you've said, and all we have to do is look at people who have had abnormal loss of the fat from the face. There's various conditions, that we can talk about. One of the things that we're seeing less and less of these days, because the medication has improved a lot, was HIV. And fat atrophy after HIV, you would see these really deep, kind of hollow, kind of very fake looking and very hollowed out eyes, and temporal atrophy. All these funny, very skeletal looking faces. For whom they needed fat injecting into their face. That's what I did do. I don't do it so much these days as fat injection into the faces for that kind of stuff.
That's such an excellent way to use fat. Wasim asked about how do you deal with fat into the face that has not good aesthetic outcomes. So I've done a few removals. I have to say, I find them, I don't do lots of them, but I have on, a number of occasions, less than 20, not too many. I've had to go in and try and remove the fat from those areas. But I find that very difficult to do because most of the people I see tend not to have a lot of volume there. And so even trying to remove that little floating fat or wherever it's gone is a little bit hard. And oftentimes, I find that the people who notice it the most are the ones who, unfortunately, pay the closest attention. And so it's like, it's almost minimally visible, but they're so now acutely obsessed with it. But that it wears on them on a daily basis. And that's the only reason I do it is because I feel that I'm actually hoping to make them feel better about their appearance so that they find something else to focus on. But I find it's very hard to difficult fat grafting.
Yeah,
to the face.
I mean, I think you've got to be so careful with fat grafting, and I just think that the temporary fillers are so good, and now they last for decent lengths of time, and they just work so well that for me at the moment, fat grafting into the face is just something that I'm not venturing into. No, it's not on my list of things to ramp up and start doing more of. I think there are other things that I think can grow in aesthetics, certainly from where I'm approaching it. And the excitement is coming from a different place, I guess. For me, that's what I would say. That was one of the questions actually that we had, was what do you think are going to be the next big things in aesthetics?
Oh, I think like everything, I think having treatments that can be done rather quickly without too much downtime is always going to be the option. Of course, there's going to be the surgeries that you can't do without having surgery. But I think being able to do a lot more, having better education on skincare, because I always look at it, the skin is the foundation, your lifestyle is the next thing, and then, from there you can either do topical treatments, injectable treatments, and then it's sort of surgery. I wanted to ask you about that though. So I also have a lot of patients who in the past have had a lot of silicone injections into their face, which we don't do anymore. And I particularly notice bad outcomes around the mouth, because with time it sort of disperses and it doesn't stay where it's supposed to. Do you remove that? I mean, are you able to actually see what you're removing if you did open up like the vermilion border or the lip, or is it really they kind of are stuck with that?
It's really, really difficult. I mean, we're talking not very big volumes. We're talking about stuff that's been injected. It's not in a bag like a breast implant. No. It's everywhere. And it migrates as well. The problem with loose silicone jelly is that it can go wherever it wants to eventually, and it does. And all you have to think about is what happens when an old style breast implant ruptures, where the jelly was runnier or they were oil. What happens is it then goes into your lymph nodes. It can go into other parts of the breast, and you can get these lumps of scar tissue, because silicone also causes a reaction. You get what are called granulomas, these lumps of scar tissue.
So nothing that can really be done then?
Well, these are reconstructive cases, full on, reconstruct.
You have to actually remove tissue and then add it on.
You've got to open them up fully. You've got to talk them into having scars in places where they may not have wanted them. It may not be possible to do this stuff from the inside. It might not be possible to do it from above. Really difficult surgery, really complicated. And you've got to, and I tell you what, it's surgery. Generally speaking, when I get patients like this, I send them to someone else, because it's not something I do a lot of. I have a go-to person that I send patients to for that sort of stuff, and it's rare for me to get those patients coming to me, thankfully. But when they do, I kind of say, yeah, you know what, I think I could do this. I'll I can try, but you know what,
you're not gonna have the best outcome for it.
And yeah, or you might be, again, if it was me, I'd want that person doing it. And I mean, the person I talk about in London, you've probably heard about a lot, is a chap called Niall Kirkpatrick.
I trained with him.
Yeah, so Niall does a lot of this and has made a real name for removing difficult permanent filler, silicone, that sort of stuff. And you know what? And he's a great surgeon. He's properly trained.
He is. He's very compassionate and very highly qualified.
Exactly. Send the patient to the best person for the job.
I agree. Yeah. You have to really go to a super specialist. Yeah. We are going to be knocked off of Instagram in 1 minute. I have a timer that is popped up on my screen. So I wanted to thank you very much for joining me tonight, and thank all of you guys for popping in. We will keep it live for 24 hours, and I will put it up eventually on, I'm not quite sure how, but once I figure that out, I will put it up somewhere.
And I'm sorry for all the people's questions we didn't answer as well. Apologies, but we'll try and get to it next time.
Yes, and if you have questions, you can send it to either of us. When I put it up, I'll tag the two of us so you can ask either one of us any questions. Thank you so much.
Thank you. Thanks, Maryam. Cheers.